What is blocking your arteries? Hi, I'm Kim McNicholas with NextGen MD and Dr. Lily Johnston. Today we're talking about the type of plaque in your arteries. Dr. Lily Johnston, before we get into the causes, can you just start naming the different types of plaque you actually see in the arteries just briefly?
Sure, I would say we have two big classes. The first is fresh thrombus or fresh clot. And that is one type of thing that we treat, and often that's an acute problem. And the rest is in a spectrum of plaque. And the plaque really comes in a lot of different flavors, but it's all really the same disease process that's going on in the wall of the blood vessel. When it's very fresh and young and inflamed, it is soft, and then over time, especially if we're doing well with our metabolic health and our risk factor modification, we can begin to kind of firm that up, stabilize the plaque, get a nice fibrous cap over the lipid-rich areas or that soft, gooey, cheesy-like pimple part of the plaque. And then eventually, when it's very old and very stable, it becomes densely calcified. And that calcium is what people think of often when we talk about plaque as well.
Okay, let's start with the softer lipid-rich plaque. What is it made of? How does it form in the artery, and why is it often considered more dangerous or unstable?
Sure. Plaque is the whole process centers around the amount of lipid-rich particles that get stuck in the artery wall. So lipid particles are transported in the bloodstream. They get into the artery wall, and we can talk about what drives that process, but they get
Yes,
stuck there.
please.
It's called retention. And these are predominantly those ApoB, LDL containing particles, and if they get stuck in the artery wall, they kind of stick there like Velcro. That is a danger signal to the body, which then activates the immune system. So we get our white blood cells involved, and the white blood cells try to go deal with that stuff that's stuck. Well, while it's been stuck there, it's starting to rust, it's starting to oxidize, it's starting to kind of rot, and the macrophages or white blood cells then take up that plaque to try to get it away and stop more oxidation from happening, and we get those foam cells. So it becomes kind of like the white stuff in a pimple, right? It's this cheesy material that is very inflammatory. The immune system is very active. It's sending out all these signals like, hey, there's danger. We got to do this. And some of that immune system also has enzymes in it that will kind of eat away at little fibrin layers, like little scaffolding layers that cover over the top of this lipid-rich core. If you erode those layers and that lipid-rich core explodes, that's a plaque rupture. And it's like a volcano erupting or like popping a pimple. And all of a sudden, all that gross inflamed material is available to be seen by the flowing blood. Well, that creates an acute clot because all of that stuff causes a huge amount of inflammation and platelet aggregation. And that is really what causes heart attack, stroke, and acute limb events. So is when we have these plaque rupture issues in existing plaque. There are other reasons for acute limb ischemia, but is certainly in the setting of what we would call in situ thrombosis or pre-existing plaque that then ruptures. That's what we mean by this soft, vulnerable plaque. If there is a much older plaque that has a really tough rind over top of it, it's much harder, like, the rind of a watermelon. And then it doesn't really allow that plaque to rupture or, like the volcano can't erupt anymore. That crust is just over top. It's too hard and firm. If it's not vulnerable to rupture, then we still have some narrowing in the artery wall, but we don't necessarily have this acute risk for heart attack or stroke.
Okay, so we might be a little redundant as we go through, this journey today, but many patients actually hear that cholesterol is patching. It sounds like that might be a simplified version of what you were saying. They patch the damage along the artery wall. Is that really a helpful way of thinking about how soft plaque forms, or is something else really happening at the endothelial level?
There are a lot of things that predispose the stickiness of cholesterol molecules in the artery wall. But if you think about where plaque forms, it almost always forms where the artery will branch or where it takes a turn. And that's because just thinking about like a river, where a river turns, They're on the inside of the turn, the speed of water flowing is different than on the outside of the turn. It's faster on the inside, right? Just like race car drivers and horse racers want to be on the inside track because that's the fastest way to get from A to B. The blood flows fastest there and it's more sluggish on the outer curve. That changes the pattern of stress on the wall of the artery, and it actually reduces something called shear stress. And when we have these points where we reduce the shear stress, the artery behaves differently. We start sending different signals about nitric oxide and vascular adhesion molecules, and we start stressing the wall of the artery. And that encourages some of these inflammatory processes. And yes, we then get cholesterol sticking in those areas where it doesn't necessarily stick in other parts of the artery wall.
How about the ones that the small dense LDL particles that actually eke inside and push the artery wall out or so? And that's where they're talking about, right? The hardening of the artery. The point, what causes that? What causes the damage to the artery? You talked about a little bit of the stress, but there are other factors that may cause cracks in a sense or damage to the artery walls, allowing those little ones to eke in.
Sure. Significantly elevated blood pressure chronically can cause damage to the endothelium. Significant elevations in blood glucose over time. The endothelium and the glycocalyx is very, very sensitive to the sugars that are circulating in our bloodstream. So if our blood sugars are persistently elevated, that will cause issues to be more permissive for those small dense LDL particles to get across that wall and stick there where they don't belong.
Okay, fibrous plaque. How does it evolve from softer plaque? And I know we're being redundant. I just am going through basically a lot of questions have been sent in, and some of our patients have very specific questions. But what is fibrous plaque? How does it evolve from softer plaque, and how does its stability and risk profile actually differ?
Mhm. So I was just at a meeting and Dr. Art Agustin of the Agustin score for coronary calcium scoring, he was there and he was giving a talk, and it was really great to see kind of his evolution of thinking of plaque and atheroma and all it. And he was showing a bunch of the AI overlays for CT angiography. These are all in the coronary circulation right now, but maybe someday we will have it for the legs as well, I hope. But he was showing the evolution of these plaques from this very inflamed, very soft, lipid-rich core, then over time progressing into the more fibrous plaque with that tougher fibrous cap, and then finally into the calcified plaques that are much older. So I think of this as a time frame evolution. They're not really separate plaques there or like separate processes. It's more like the timeline, what happens to plaque over time. So if we can help subdue the inflammation, if we can reduce these plaque rupture events on the inside, because there are times when the plaque will have a small plaque rupture and the body then heals it, but we have to sort of change the inflammatory signal because different kinds of white blood cells are actually responsible for making the nice fibrous cap versus the ones that have that sort of demolition scaffolding thing that break it all down and create a risk for rupture. So if we can calm things down, get risk factors under better control, then we allow the immune system to start building that fibrous scaffolding that thickens that fibrous cap, makes those plaques less likely to rupture, and stabilizes them over time.
Since you're talking about plaque rupture, I want to jump to one of Melissa T's questions. She sent me quite a few of them. Are there tests that can suggest plaque instability, and why are some of them considered experimental? She had gone to her doctor and had asked for the LPPLA2 and MMP9, which she had heard on one of our other, podcasts, and the doctor said, no, we don't do those here. They're not gonna do any good. They're just experimental. There's not enough evidence. I'm curious your thoughts.
I think that they are certainly relevant in a sort of at a population level, right? We know that these factors are important. We know that they correlate with increased risk of events. I think at the individual patient level, it's hard, especially for, classically trained doctors who don't nerd out on this all the time to understand how that impacts a particular patient. And for them, it might not change what they would do. I think from an individual perspective, imaging is probably a better tool to understand the amount of vulnerable plaque that we have. And the CTTA, or CT coronary angiography with the dye, is probably the best way to look at that. In the heart, we don't yet have a way to look at it in the legs. We are starting to do some more involved plaque imaging in the carotid arteries in the neck that go up to the brain. And some of that is done with
Kind of
actually
important.
MRI. It's not the same as the CCTA, although we often get those. But the plaque morphology can sometimes be done with ultrasound if you have a very sophisticated lab, which is not very common. Or sometimes with MRI, we can see plaque hemorrhage. Again, I think those are very specific sequences with the MRI that are not routinely done. I wouldn't know how to order one in my hospital. So those are also going to be quote unquote experimental. We do know that they exist and that they can be done. Whether that changes decision making for an individual patient in terms of how we think about risk factors, how we think about getting blood sugar under control, getting blood pressure under control, getting our small dense LDL particles under control. Like, how do we, does the presence of a soft plaque, I'm just going to assume you have soft vulnerable plaque. If you come to me and I see plaque, now I can look at an ultrasound in the neck, and if I can see the difference in the neck plaque between soft plaque and calcified plaque. Actually, just looking visually, that's pretty easy to tell. But it doesn't mean that
Calcium trail. Talk about
yeah, you can
that
see it on
more.
ultrasound, but if I see somebody else's ultrasound that was done elsewhere, I don't know if that sonographer
Oh,
captured all of the plaque that's there. So they might see a calcified plaque, but maybe there's other soft plaque, which is actually very hard to see if you're not really looking for it. We might not know if it's there. So,
interesting.
it's not a perfect test.
And under X-ray, you can see if there's rock hard calcium. Can you talk about that?
Sure. So
You have a
we
calcium
know,
trail.
for example, if you go to the dentist and your dentist gets dental x-rays and they see calcified blood vessels, that's a good sign. You should go talk to a vascular specialist about making sure your risk factors are controlled. If you get a mammogram and they see calcium in their blood vessels, that's another good sign. You should go talk to somebody who can help you make sure that your risk factors are under good control. We see it in x-rays all the time. People see the artery bones, right? The outline of the artery is visible on a plain old x-ray because it's calcified. So you can't see anything else besides the calcium. But if you see calcium, for sure, there has been plaque that has then stabilized over time, but there may be more plaque, right? Calcified plaque, we think, especially in an average first-time imaged person who's not been on medications or other interventions, probably represents 20 to 30% of their plaque volume. The other 70 to 80% is going to be non-calcified, potentially soft, very vulnerable plaque.
Okay, so Melissa T has a couple other questions here. I'm going to combine. Do most patients have just one plaque type? You're alluding to they have multiple, but I'm just stating the question. Or do you usually see a mix of plaque types within the same artery? And is one plaque type more unstable than others?
We often see a mix of plaque types in the artery, again, depending on how old they are, how long they've been there, and how well controlled our risk factors are. So we have talked about whether increasing calcification represents an increase in disease burden, like there's just more plaque total, or whether it actually represents stabilization of existing plaque. And to know that, you do have to have some of this more advanced imaging testing. But again, as I was listening to Dr. Agatston speak, he has case examples where he's taken patients who have, again, maybe 20, 30% calcified plaque and 70% scary non-calcified plaque, soft atheroma, and with good risk factor modification, using nutrition and exercise and medications when necessary, has converted a lot of that plaque to calcified plaque, but there's not been an accumulation of additional plaque. So that speaks to the ability with good targeted therapies for us to either regress or stabilize this plaque. And it's absolutely possible. It probably should be the new standard of therapy, and how we monitor that over time is another conversation completely. But, typically, and again, in the first time patient who presents with no real treatment, who just has a positive calcium score, or, got a lifeline screening and has an abnormal ABI, we will assume that there is both old plaque and new plaque, meaning soft plaque and calcified plaque.
Just wanted to mention, we talked about imaging, but the intravascular ultrasound is always, I would imagine, really fun for you when you go in. Can you talk about this additional imaging that doctors use during an angiogram that gives you a better picture of what you got inside your arteries? I mean, under the X-ray, we said, I mean, you can see if there's a calcium trail, if there's rock hard calcium, just as you can see a bone under X-ray, you can see the calcium in the arteries as well and the hardening there. But you can see a lot more when you use the intravascular ultrasound as well.
Sure. We can see again, is that plaque in just one spot in the artery? Is it going all the way around? How much narrowing do we really have? We can see that with intravascular ultrasound, and that's nice because sometimes even with the dye, you only get one projection. It's hard to tell exactly how narrowed it is, but the intravascular ultrasound allows us to capture that. I don't have as great a feel for exactly how old or fresh that plaque is with intravascular ultrasound. It's a little grainier because there's blood flowing past it all the time, and it's a little harder to tell. But certainly, fresh thrombus is like sometimes it moves inside the artery as you're watching it on IVUS, and that is a little terrifying because it means it might fly off and go somewhere that you don't want it to. But there are definitely some different characteristics of things in the arteries that we can see with IVUS.
And just so people know how skilled you are, and the folks that really go in, you can tell by feel in a lot of cases.
Oh,
You have a really
absolutely.
good sense.
Yeah.
Yeah.
So I know that you had a really fun video kind of showing exactly how soft versus firm some of these plaques can be in terms of like what does fresh clot feel like versus plaque and the different stages of the plaque, like the fresh, soft, ugly atheromas versus the really densely calcified, stable plaque. And you can absolutely tell, with your wire, how easy is it to cross, how smooth, like if I send a wire through an area that is completely blocked or 99% blocked and the wire just flies right past it, I am thinking, oh gosh, this might be a fresh blood clot. Maybe it came from the heart. I don't know. But if the wire just sails through it like butter, I'm very worried that that's super soft, vulnerable plaque or fresh blood clot. If I, bounce up against it and it sort of has that boink, 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 like it doesn't go anywhere, it just bounces right off the cap, then that's been there a very long time. It's very chronic. And, we can poke around at it. We might have to come from the foot to get on the other side of that cap to really get across it. But absolutely, you can tell with wires and the appearance of it both what kind of plaque you've got.
I talk about this all the time. I love that you say that if you can't get through the cap at the top, going through the groin, a lot of doctors now, not all of them yet, but there are more doctors that are more comfortable with it that will take a retrograde approach, come up from below, either through the foot or the cap, sometimes behind the knee if it's up a little bit higher. Um, why is that cap below typically a little bit more amenable?
So if you and people have looked at the cap morphology and whether it really is more amenable all the time. I would say most of the time it is, but there are actually some interesting papers that, look at the shape of the cap and whether or not you'll be successful coming retrograde or from the other side. But if you just think about kind of how the pressure dynamics work on the top end, right, it sees the systemic blood pressure. So it is sort of battling that, optimally 120/80 number all of the time. And it's really kind of hardening against this full flowing river. The other side coming from below, well, you don't have systemic pressure anymore because there's an obstruction up top, right? So this is like the pressure in the other side of a dam on a river, right? You're not getting that full flow, you're not getting all that back pressure. So I don't think there's nearly as much signal to like really batten down the hatches and create all that additional scaffolding to protect that plaque. So the cap on the retrograde side tends to be much softer and more amenable to crossing.
And one of the questions that has, came in late that I didn't have a chance to go up there is why do collaterals not seem to block with calcium? You might get some clot in there, but do you find that calcium builds in the collaterals as well?
I think you will ultimately get plaque forming everywhere. You just have to remember that this process takes sometimes years or decades. So if the collaterals are new and we're working around areas that are narrowed or blocked, it may take us years before we see calcium. We might start to see plaque form if we're not controlling our risk factors, and we still have ongoing plaque formation processes. But overall, I would say it just takes a long time to get there. But if you do it long enough, you will see plaque form and calcium eventually get deposited. But hopefully, in our patients, what we're seeing in the collaterals are patients who have been exercising, who have been on, an appropriate nutritional strategy and are on medications that are appropriate. And so hopefully they're not laying down new plaque and therefore shouldn't lay down new calcium in those beautiful, lovely leg-saving collaterals that they are building with their exercise over time.
And Tracy has several questions in here, and they're all kind of, and they're related. And actually, one I would even combine Daniel R in here as well. But she's asking, are there plaque types that can actually be reduced or reversed without surgery, or is plaque permanent once it forms? And she's really asking that because there are a lot of supplements out there. They claim they can melt plaque. Is that based on any real biological processes? Things like pomegranate, there are supplements for pomegranate saying pomegranate actually, melts plaque. But what are they talking about?
Well, I would be very wary of any supplement claims in general, so let me start with that. But it is possible to regress plaque, meaning to have a, plaque that's the size of a speed bump that then comes down to, just a little itty bitty bump in the road. The plaques that can regress are the ones that are still very soft and lipid rich. And if we end up with really good reverse cholesterol transport, we may be able to get some of that lipid out of the artery wall, some of the inflammation out of the artery wall, and some of the fluid, really, the edema. Uh, so we absolutely can see plaque regression. The only things that have shown plaque regression with, either an angiogram or IVUS, any of our really sophisticated imaging technologies have been aggressive lipid lowering therapy with either high intensity statin or the PCSK9 inhibitors, Repatha and Praluent. And so that is really what I know to quote unquote melt plaque that exists now. Yes, there are a lot of supplements that have shown regression in IMT, or intimal medial thickness. That's the thickening of the lining wall of the artery. There's one nattokinase study that showed regression in IMT. Estrogen shows regression in IMT actually when started appropriately postmenopause. But whether that's melting plaque or not is really not the same thing. And I would not trust. I mean, first of all, a supplement really can't make those claims because that's treatment of a disease, and no supplement should be marketed for the treatment of a disease. That's not legal. But
But they are,
beyond that, if
right?
some influencer on YouTube says it, well, I would still perhaps, and I say that as an influencer on YouTube, right? I'm sorry for things they have said. The marketing clickbaity thing about dissolving plaque, melting plaque. I'm sure that it generates better click-through rates, but it's not necessarily factually correct.
So Daniel R is asking, is lifestyle change more about preventing plaque from becoming unstable or rupturing rather than removing blockages?
It is important no matter where you are on this journey, partially because the lifestyle changes also help modulate our immune system, and they modulate the inflammation that's going on in the artery wall, and they modulate our ability to have vasodilation with nitric oxide through exercise and forming more collaterals. So I don't think that it's ever inappropriate or wrong to focus on lifestyle interventions. I will say we can probably stabilize plaque with lifestyle. Whether that's all you want to use, that's really a risk-benefit conversation with your physician based on what we know about the ability to stabilize plaque with modern pharmacotherapy. There are people that are open to that, people who are not. I get it. All that said, the best evidence, in my opinion, suggests that if you have significant plaque burden, the fastest way to stabilize that plaque is using modern pharmacotherapy.
Yeah, and that brings me again to the statins. And just to make sure that we cover all of Kevin H's questions here, I'm just going to run through them because I think you've addressed some of this. But do statins actually reduce plaque, or do they mainly lower cholesterol numbers? If statins reduce plaque burden, which plaque types are affected and how does that work biologically? Is plaque stabilization a more realistic goal of statin therapy than plaque removal, or are we talking just lowering inflammation? Can you
Yeah.
put that
Statins
all into one?
stabilize plaque both by reducing the amount of lipid that is available to go into the plaque, right? Because that's a feed forward process. When it's inflamed, then more lipid is actually getting into the wall and then getting oxidized and then getting eaten up by those macrophages. And also, it's lowering the inflammation, right? We actually can show that statins reduce whole body inflammation when we look at the high sensitivity C-reactive protein or HSCRP marker. All of that combined does help stabilize and or regress the plaque. I think stabilization should be the goal because that alone should prevent heart attack, stroke, and limb loss. Now, everybody likes regression. Everybody would like to have less plaque, and it makes all of us feel good if we do that. It's really hard to measure that we're doing that. You'd have to have multiple CTs with this AI analysis over top of it to really prove that. But um, we have shown it in some trials. If you're very careful about how you measure things, you can show regression. Some people believe that that is directly related to, again, lowering inflammation and getting the fuel for that forest fire under control. And right, forest fires burn trees, and so you got to kind of get those trees down, and that's the small dense LDL in particular, but the ApoB burden in general. And bringing that down with lipid lowering therapy is absolutely part of the process. Bringing down thrombogenicity with antiplatelet therapy is also part of the process. You'll remember from our statin episode that antiplatelet and lipid lowering are both recommended as part of the guidelines for the management of both coronary disease, carotid disease or cerebrovascular disease, and lower extremity PAD.
And Katie R, she was told that her plaque was clot, and come to find out it was not generally clot, it was actually rock hard calcium. And so she is wondering, why do doctors tell patients they just have a clot when the blockage is actually rock hard calcium? She goes on to say, isn't that confusing for patients since clot, soft plaque, and calcified plaque have different causes, she believes, and prevention strategies and treatment strategies?
I don't know why doctors might do that. I mean, I certainly think everybody is trying to make sure that there is just a basic understanding. And so most people think that the only thing you can have in a vessel is a clot. And so perhaps it's just a lazy turn of phrase or convenient turn of phrase. I certainly hope that the physician would appreciate the difference between a fresh clot and calcified plaque, but not, they may be just trying to keep things simple for a patient. I'm not sure.
And that's what I think it is, but I think that it offers it's a disservice for not taking, the time. And I always say, if you don't have the time, write it down, send them to us, and then we can help, and we can share great video content and explanations from doctors like you, where patients can better understand their disease. I just gave a presentation for BT. It was my first keynote. I was so excited, and
Congrats.
I thank you. And I was talking about this very thing, that you do need to take the time with the patient. If you don't have time, how do you expect a patient to comply with doctor's orders for lifestyle modifications that they don't even completely understand their disease? They're going to go home, they're going to Dr. Google, and the only thing they're going to see is they're going to be dead in 5 years, and then they're going to crawl into a hole, fall through the cracks, and they're only going to emerge a year later in the emergency room with a wound that's not going to heal and amputation as an option. So, I mean, that's I know that's extreme, but that's what we see every single day, with our PAD Saver hotline. But taking the time to talk to the patient and to explain things. And if you don't have time, don't just send them on their way to Dr. Google. Send them to specific organizations, right? Like ours, so that we can get them to the right areas and share the right content with people, whether it's through us, through your channel, through the American Heart Association, American Diabetes Association, the Society for Vascular Surgery as well. They have a great website. I think it's Highway to Health, that has great content. So, I mean, there's a lot of great stuff out there, but I always say to the doctors that I speak with, please, God, do not send them home to Dr. Google because you will regret it. You may never even see them again, except in
Hmm.
the emergency room or on deck for amputation. So I love that you take the time, with your patients, not only through your regular practice, but then additionally through your metabolic practice. Which, by the way, off topic, you at one point when we first started said that you were working with scripts to actually combine and bring in your metabolic practice into the vascular clinic. Is that happening?
Yeah, it's happened. Metabolic clinic is up and running.
I love it. We have one of our good friends here, Imelda, that she wants to make an appointment there. So we're going to tell her then to go ahead. She's so excited. She watches your videos faithfully every
Oh,
single
that's
week.
very great. I can't
So
wait to meet
she
her.
is, oh, she is so excited to meet you. Okay, just a few more questions here. And then we'll let you get back to clinic. Heinz has been asking every single doctor this question over the past few months. Have you ever seen plaque that contains foreign material like microplastics? And does that change how plaque behaves?
I don't think I can see the microplastics in plaque because they're micro. So what I do know is there was a New England Journal of Medicine article that was published maybe a year or two ago now that looked at the plaques that we fish out of the arteries in the neck, the carotid artery plaques that we do when we do carotid endarterectomy. And many of them do have microplastics in them. And I was just horrified when I read this because we are not sure how to reduce exposure. We're not sure actually whether we inhale them, right? If they're aerosolized in our air pollution, if they're coming in from the water, if they're coming in from our food and our Tupperware, are we absorbing them transdermally? Like nobody knows where this is coming from. I have seen like a probiotic supplement that actually claims that the bacteria in it will like absorb microplastics and get them out of your system. I have no idea whether that works. The article, as I recall, did show that the plaques with microplastics were more severe in some way than those without. But I don't think we have any way of knowing based on a regular CT scan or an ultrasound whether any given plaque is related to the microplastics. We also sometimes, this is a little off topic, but we will see fragments of bacteria in plaque. And it's like the um, pathogens that cause gingivitis or periodontal disease in the mouth will actually show up in artery plaques in the neck or in the legs. So like, please brush and floss. Dental health is related to your vascular health and to those plaques in some way. So are the microplastics, but we don't really know what to do with that information yet. And probably, yes, the plaques are somehow more inflamed, but stay tuned. I think not enough research yet.
Okay. I love this question. We get asked this all the time, and the patients just don't seem to get a straight answer, but I think we're going to get something more straight from you. But whether taking calcium or D without a K2, whether it increases artery calcium. So, does what you take supplement wise end up in your arteries? And secondarily, should we be taking vitamin K2 with vitamin D3 in particular?
So vitamin D3 will cause your body to absorb more calcium from the gut, from the foods that you eat. Typically we don't see an enormous rise in serum calcium levels on a lab test until vitamin D levels get very, very high. Like, I don't even want to give you a number, but much higher than even my well-supplemented patients achieve. We don't really think that that has a direct impact on calcification of the vessels. And the K2 story is very interesting because certainly people who have a higher dietary intake of vitamin K2 tend to have less plaque and less heart disease. We have not shown yet in a randomized controlled clinical trial, and there have been several, any benefit of taking K2 on cardiovascular outcomes. We're not even sure we see a reduction in calcium in blood vessels. One study showed maybe there was even more calcium in some people's blood vessels on K2. In general, I don't think that the risks are high. I haven't seen adverse events in those randomized controlled clinical trials. I tend to like including it with vitamin D supplementation, but it's really not that evidence-based. We don't have a trial that says it's a good idea or that it reduces any bad outcomes. But I think the risk is low and there is some potential upside. No trial is perfect and they were small. There are all kinds of reasons to think that they may not have given us the perfect answer. So I think it's reasonable to err on the side of adding K2 to your vitamin D3 supplementation. I do think vitamin D3 is an important hormone in the body, both for immune function and general well-being. And so I do like to get people to what I would consider, a more optimal level if they are not there by themselves with just sun exposure and a good dietary strategy. That said, no evidence that it has a specific role in inflammation or plaque in the vessels, and the K2 story is still evolving.
What about calcium in general? My mom was always told to take calcium for her osteoporosis.
Yeah,
People
I would
worried about
say
taking a bit.
people who don't take any dairy, who don't have any dietary calcium, maybe it's reasonable if they have osteoporosis and are also getting vitamin D supplementation to absorb that calcium. The one really big study showing any impact of calcium supplementation in women actually showed a small increase in mortality. So in general, I try to stay away from calcium supplementation if I can ever avoid it.
Okay, throwing out that bottle. One final question here. With everything patients are hearing about plaque types, instability, and progression, this is Lisa O. She wants to know, is there actually hope for managing this disease long term?
Absolutely. There is always hope. And I think the more we understand about plaque and the earlier we start finding it, the more hope there is. But even in people with very high calcium scores in the thousands, we are able to stabilize plaque that they have. Many of those patients can go on to live very healthy, happy lives without major events, as long as we are aggressive about managing all of the different things that contribute to ongoing plaque formation, plaque rupture, and instability.
Thank you so much, Dr. Lily Johnson. Appreciate you so much. This has been literally incredible. I almost wish in this moment that we have the Heart of Innovation show on Saturdays, and I wish that I would have thought about this ahead of time to use this to for one of our episodes on Saturday, because I think that this would blow away that entire audience. We might have to revisit this again and
Happy to.
lay it right back. But thank you so much. Make sure, if you're watching this right now on YouTube, please like this video. It helps get the word out. YouTube will algorithmically prioritize those videos that a lot of people like. Also the channels that a lot of people subscribe to. So please, if you can, make sure to subscribe to youtube.com/the @Lily Johnston, MD, LILYJOHNSTONMD, and also youtube.com/the way to my heart. Thanks so much, everyone. And if you have more questions, call our Leg Saver hotline at 1-833-PAD legs.